Well, good evening, everyone. It's so good to have you here at our virtual annual meeting. My name is Paige. I'm the Executive Director of the Northern Colorado Medical Society, and so pleased to be welcoming you to our event this evening. I hope that you got your food from the Rio if you chose to do that, and you also got a margarita to cheers. But I started back with the Society in September, and it's been a true honor to get to know so many of our physician members, and also just the opportunity to get to know all of you as we continue on. And as you came in, you saw a couple advertisements scrolling through on the screen, one of them being for our podcast Stethoscope, which launched December 1st. So be sure to subscribe to that if you haven't yet. There's 4 different episodes on there so far. We have a lot more rolling out, and we're always looking for new guests on the podcast. So in a moment here, I'll put information in the chat, but if you're interested in being our next guest, please feel free to email me. I would love to have you on our podcast. I also want to make sure that we welcome some of our guests this evening. We do have some students from the University of Colorado Medical School, Fort Collins branch, medical students with us, and we also have faculty as well. So welcome to you all. And then of course, want to welcome as well our guests from the Colorado Medical Society. As y'all know, the Colorado Medical Society works with each component society very closely, and we value their partnership. Finally, just a little bit of housekeeping for the evening. In the virtual events, although it seems odd to celebrate from afar, we want to make sure that we do, because we had an amazing year and we have so many great things to celebrate tonight, like our Physician of the Year, new leadership, and of course the amazing leaders that gave so much this past year. So be sure to use your emojis, the smiley faces, the claps, whatever you can to make sure that we're celebrating together. Finally, I'm just going to ask to get us started to do a quick toast. So if you have a drink in front of you, you can hold it up to the camera and toast, and just toast to 2021, and go ahead and put in the chat something that you're excited about in 2021 if you want to. It doesn't have to be NCMS related, but I know what I'm excited about in 2021 is our virtual education series that's going to be launching, and we're going to talk about that tonight, but that's something I'm truly excited for. So feel free to put in the chat something that you're excited for, whether it's NCMS related or in your life, what you're looking forward to this year. And with that, I am pleased to bring on to our virtual stage Dr. Claire Murphy, the current NCMS president.
Well, cheers, everyone. Good evening. It's wonderful to see so many familiar and also some new faces. We have a great evening planned together. Up next, you'll hear from our keynote speaker, Dr. Sylk Sotto. Following her address, you'll meet third-year medical students who have been in our community. And immediately following, we'll go into our business meeting. During our business meeting, we will present both a Physician of the Year award and our Legacy Scholarship, provide a financial update, and hold our election for the 2021 NCMS leadership slate of candidates. To conclude the evening, you'll hear from Dr. Ted Norman, who will talk about some of our new initiatives and present a gift to the medical students who have joined us this evening. But before we get started, we'll hear from Dr. Lembitz, the Chief Medical Officer at COPIC, one of our great annual sponsors. Dr. Lembitz, thank you for being here. I yield the floor.
Great, thank you. So I have 5 minutes, and I thought with the given 5 minutes, I would sort of walk us back through the last 11 or 12 months and the issues and the phone calls and the things that COPIC has been answering and helping you with. So let's roll it all the way back into February or March of last year, when I was on hotline and we got all the shutdowns happened, and we got just basically bombarded with the different phone calls related to non-standard practice. Can I see people in their cars? Can I have a parking lot as their waiting room? How am I going to do this? All the telehealth. How do if I don't have PPE, how can I manage these patients? Can I send the patients over to the ED? And then we also dealt with the different varying issues of immunity. There was the federal immunity that happened for COVID countermeasures. We never actually got anywhere with the state immunity. You have CMS folks here if you want more input from that, but it wasn't for lack of trying. It was an enormous battle of trying to get and I don't even know what the GEER committee stands for, but it all had to do with whether or not we declared an emergency declaration that then conferred immunity. Fortunately, we never quite got there, but unfortunately, there wasn't any state immunity related to all this. Then we'll fast forward to what happened in late May and June. after all the shutdown, the return to elective practice and elective procedures and surgeries. I mean, the numbers of phone calls we fielded there, whether there was mandatory testing, how you would manage these patients. Did you need an informed consent for elective procedures to talk about the potential risks of COVID? All this, the reason I'm kind of giving this to you is prospectively, we were just, swimming underwater, and retrospectively now it looks relatively clear, like we may have found a pathway that made sense, but that's the power of retrospect. Then we headed into the summer months, and I'm sure a lot of you were phone callers of what do I do with these non-compliant folks that don't want a mask, who are endangering my staff and my facilities. Can I mandate masking? Can I kick them out of the practice? Can I do those kinds of things? And then the inevitable questions we had related to exposures, which was, I know a patient or I had a patient in the waiting room that was then subsequently proven to be COVID positive, or I had staff members, who the quarantine and the isolation procedures related to that. Well, now we're into a different, the good news is, think back of all the answers to all those questions I just went through that seem so difficult. And I think we don't get any phone calls on them now, because I think you got them all dialed in. But now the question is all about vaccine access and what I would call line jumpers. How do you deal with folks who are trying to press you into jumping the line? I can't predict, just like I couldn't predict a year ago when I took hotline call in March and April, what would be the next line of calls. But, it's kind of nice when I get a garden variety old, adverse outcome disclosure to the family type of clinical case that doesn't have anything to do with COVID. The good news is we do not see yet claims related to failure to diagnose, failure to treat COVID cases. And it's actually also a national trend that we don't see those yet. Now, I'm not sure whether I wouldn't rest too greatly on that. The courts have been closed. They're slowly opening up in different areas, but they're still closed. So we don't know whether they're going to subsequently file those kinds of things. We do know that long-term care cases have already been filed, and class actions in long-term cares have already occurred. So that's an area that probably doesn't affect many of you. So that's a quick look back into the year that was from a medical, legal, and COPIC standpoint. The only other thing I would just sort of add to what I have 5 minutes of what be important to say is please remember that the Candor bill was passed. We now have excellent processes in places to determine whether the right tool to deal that gets the right result for you or your patients and families, whether that be 3Rs, whether that be Candor, or whether that be traditional claims route. The bottom line is, it means more than ever to call us, discuss cases with us, and we meet actually weekly with a whole multidisciplinary team of claims, legal, patient safety, risk management folks to look at every case that comes in and try to determine what the right tool is for that given case, whether it be 3Rs, Candor, or traditional claims. And we revisit cases that are tough. So sometimes you don't know when you call it in which way it's going to go. So bottom line is just, reach out, and I think we'll be there for you. With that, I'll close. I didn't get any food from the Rio, but I'm not quite back in my. Many of you know that you're my hometown. That I grew up with you all in the Greeley, Loveland, Fort Collins area, so it's still near and dear to my heart. And happy to take questions, calls, or do whatever as you need to. But that's my 5 minutes.
Thank you very much. So without further ado, I want to warmly welcome our keynote speaker for this evening, Dr. Sylk Sotto, Assistant Professor of Medicine at Indiana University. Dr. Sotto is the Vice Chair for Faculty Affairs, Development, and Diversity in the Department of Medicine at Indiana University School of Medicine. She co-chairs the school's Diversity Council, serves on numerous institutional committees, and teaches several courses, including research ethics, culturally relevant practices in medicine, and Foundations of Clinical Practice in the Spanish Immersion Program. NCMS is committed to forwarding the pillars of diversity, equity, and inclusion. Your board of directors took their first step in this commitment by participating in DEI training this fall or last fall, and have written specific diversity, equity, and inclusion goals into our strategic plan. Tonight, Dr. Sotto will be addressing NCMS members about cultural humility as a framework towards health equity as NCMS begins to educate our members on integrating diversity, equity, and inclusion into their daily work. Welcome, Dr. Sotto.
Thank you very much for having me. I'm really happy to be here with you all. I felt, like I said before, cheated completely on the Rio margaritas, and then on the opportunity to go back home to Colorado. I'll let Paige work her magic there. Paige, would you like me to just say next slide? Is that?
Yes, please.
Okay, great. So let's go to the next slide. I will talk to you today about cultural humility as a framework towards health equity. My immediate disclosures: I don't have any conflict of interest or commitments. The opinions that I will present to you today are my own. They do not represent the institution affiliates of my professional societies. And I have my own biases like everyone else, and they may come through as I speak to you today. But I will leave a little bit of time to ask for you to ask any questions related to this framework or anything that I may offer to you today. Next slide. So I came across the concept of cultural humility in 2008 or around that time as part of an ethics program that I actually was doing at University of Denver. By the way, my undergrad is from Colorado State, so a shout out over there to any Rammies in the audience. I see a few of you there. So at that time, Drs. Turvalon and Moira Garcia had published it about 10 years earlier, so in 1998. And I remember reading it and thinking, well, but of course, you know, what's so special about this, right? It's humility. I met Dr. Turvalon actually a few years ago, and let me tell you that it was one of the best professional experiences of my life. I realized that in many ways, in the same way that I think about the Belmont Report in relation to research ethics, that I think about the principles of beneficence and justice and respect for persons, that humility is something that goes hand in hand, that it's not a complicated concept, right? But I will offer that the humility that we're going to talk to you today, it's related really more to cultural humility, to the ability to actually say, I don't know, but I am curious. So it's not so much about the kind of humility that may show up in terms of modesty or meekness or any lack of pride. So the humility will be really centered around this reflection and lifelong learning process. Next slide, please. So when, you know, you may think, well, why cultural humility and why is this concept relevant today? Because somewhere along the lines, along the way, we have failed medicine's oath and mission, and we continue to do so, right? Then we know that the literature and the studies tell you, and probably in your own experience, you have seen that people of color receive lower quality healthcare in some places, even when a lot of these conditions are comparable. We know also that the studies tell us that they have been treated with disrespect by the healthcare system, that they may believe that they receive better care, though they would receive better care if they were of a different race. And obviously, you know all the major disparities that exist in key diagnostics area. Next slide. So what is cultural humility? So as I mentioned, this was put forward by Dr. Turvalon and Moira Garcia. We will discuss it today. Think about culture in a way that is not narrowed by ethnicity, religious, nationality affiliations. Think about culture in the broadest sense. because most of us navigate different cultures every day. It can be work, it can be our own home, it can be the communities that we serve. Many times we use this holiday exercise with the medical students, and we ask them, tell me a little bit about what is generally served at your table during the holidays. And after we go through the whole class, we realize, oh, everybody's household is different. And I have learned some pretty cool dishes as well, but nothing that I would expect a typical meal. So in that exercise, students really realize that every family is different, every work culture, every climate of your unit or your practice. So think about yourself to begin with as a combination of cultures that are completely tied to your own identity. Okay, next slide. So what exactly is cultural humility? So they define cultural humility as this process of self-reflection and discovery in order to build honest and trustworthy relationships. It is this lifelong process of self-reflection and self-critique, whereby the individual not only learns about another's culture, but one that starts with your own examination of your own beliefs and cultural identities. So it states that cultural competence is not enough, that you need to actually reflect on who you are in order to treat others in a way that is definitely advancing health equity and equity patient-centered care. Next slide. All right. So I wanted to share with you a little experience I had a few years ago. You yourself might have been trained under the cultural competence framework, especially if you studied after 2000. LCME accreditation of the medical school asks that students actually demonstrate an understanding in which people of diverse cultures and belief systems perceive health and illness and respond to various symptoms, diseases, and treatments. So it was, and it is, a novel introduction that has taken us to a notion that perhaps competency actually equates expertise. So a few years ago, I received an email that said, Dr. Sotto, and I paraphrase here, it said, do you know who is culturally competent in African culture? Well, I don't know if you know how to use the thumbs up, thumbs down on Zoom, but usually I ask people to tell me, does this question make sense? That you would ask, where can you find somebody who's competent in African culture? The question is obviously not fair. If you think about the African continent and you think about all the countries and within those countries, all the variations, you know that this was not an easy question. The patient was actually from Kenya. He had been living with his daughter for quite some time in Indianapolis. And in providing palliative care, the team was doing all the things that they thought were critical in terms of cultural competency. Let's check the next slide page. So in terms of cultural competency, that is the capacity to function effectively as an individual. It is the understanding the importance of social and cultural influence on patients' health, beliefs, and behaviors, but it doesn't quite get us there, right? It assumes that at one point you will be competent in all cultures, right? And that doesn't make sense, all right? Next slide. So the things that they were trying in terms of cultural competency were things that you're probably practicing today, right? You may use interpreter services and all these other examples of recruitment procedures, training, using community health workers, using culturally competent health promotion materials, including family and community members in the conversation. All those are key for cultural competence. However, and next slide. If you think again about my patient and the story that I was sharing with you, you may think, well, what was the problem then? If they were doing all the things under cultural competency as part of key physician-patient communication, why couldn't they move the needle in terms of treatment or no treatment for this particular patient? I offer to you today, and I realize that that might not be a great slide since the table looks quite small, that if it provides at least this difference between cultural competence and cultural humility. So under cultural competence, you may actually focus on group traits, and you may view culture in a very definite way. When you think about cultural humility, you're really looking at the individual as a unique. You're really thinking about the multiple contributions that individual is making. It can be fluid and change based on the context of the conversation. In cultural competence, you think about minority groups, ethnic and racial, and you may think of other groups. In here, we're really thinking about the fact that everyone follows certain traditions. You yourself follow certain traditions. We also realize that there's a power difference that exists that has to be minimized, that we have to actually promote respect, and that this is, again, part of that lifelong process, and we need flexibility when we're dealing with patients. So that is, in a gist, this difference of cultural competence and cultural humility. And I actually surfed the web a little bit to see what you're all doing over there. Next slide, Paige. So when you think again about this story and thinking about the lifelong process of self-reflection and critique, I can tell you that I said, well, let me meet with the team. Let me go to the hospital instead of trying to figure this out via email. When I met with the team and we discussed cultural humility, we talked briefly about the concept. We talked about all the steps that they had followed up to that point. And then one of the nurses actually said, I really wonder what the pastor would think. And everybody went around like, what pastor? I hadn't heard in the discussion the pastor. So when I asked who was consistently in that room, it was apparently the daughter and this pastor. So long story short, the patient was truly struggling with his faith and spirituality. It was never about being competent on Kenyan culture, because even that sounds crazy, right? Kenya is multi-ethnic, multilingual country. So the patient was struggling with his faith and spirituality, which is obviously not exclusive of Kenya. And what if instead I would have told you that the patient was from rural Indiana or rural Colorado? Would you have asked for a culturally competent provider in that aspect? Probably not. But there are things that our own biases kind of pretty much determine the steps that we will take to actually, lead the conversation with the patient. So there are other things that we need to obviously consider in our interactions with patients. There are other things that we can use to actually address these issues. And we think about cultural humility in medical education in the way that we are actually preparing our med students to think about treating the patient and not necessarily a culture. Next slide. Okay, so I did go around to try to see, what was out there. And I actually believe that this roadmap to improving health for everyone in Larimer County, I actually checked it out. One of my pillars of my scholarship is the intersection of research ethics and health equity. And I can certainly see in this particular example that there is work being done that really could be framed under cultural humility, especially the last portion that is talking about community engagement, community partnerships, and sharing power. And the way that you actually share power is having those conversations with communities, with patients, and they will guide the way. They will tell you what they want and need. So next slide. So what would it look like to actually think about cultural humility in many aspects? This one I actually introduced, especially talking about vaccine hesitancy, something that I am sure you're all experiencing. As part of my research, I'm currently looking at the Latino COVID patient population in the Indianapolis metro area. Looking at vaccine hesitancy and actually utilization of virtual clinics, telehealth, and all of those. So we were trying to figure out, okay, what else do we need to tell individuals in order to participate? So I offer you a couple of best practices here. One is in thinking in general about advancing health equity conversations, to be humble, to exercise patience, to demonstrate interest, to build relationship, to listen, to understand, to focus on the end goal, and find that commonality with the patient, because that is actually what's going to get you that trust and probably move the needle. These are not concepts that are strange to you as a physician. This is all part of capturing the history of the patient and also building that relationship with the patient. Next slide. Okay. So in part, thinking about specifically actually with the AstraZeneca study, we are one of the clinical sites. We have had to have these hard conversations. And again, this is where we think about treating the patient and not the culture, and really understanding why that particular patient is saying, no, I do not want that COVID vaccine. You may have gone through all the answers, right? All the ways that this will protect the patient, and the patient might still be reluctant to take that vaccine. Next slide. So in talking a little bit about what you can do from a framework of cultural humility, I encourage you to think about your own identity, values, and motivations. As you know, and I told you that definition of cultural humility is this lifelong process of reflection. It's where you're going to realize where your privilege lies and where opportunities for growth in terms of equity, diversity, and inclusion actually lie. So reflect on your own identity, values, and motivations. Don't assume the individual represents a group. Even myself, in looking at the Latino population, I know that I am actually treating that group as monolithic. I can share with you that I came from Puerto Rico all the way to Fort Collins, Colorado, to go to CSU. And my first semester, I just couldn't figure out why they kept taking me to Rio. They kept taking me to every Mexican restaurant in town in Fort Collins, and I couldn't figure out why. And they would ask me questions about the Mexican menu, and I have still I have no idea what chimichangas are. But the point there is that the Latino community is not monolithic. So you have to really think about where those individuals are coming from. And even then, they all have different experiences. And there's a lot of classism, colorism, even within those communities. So I offer you those examples. Ask questions and listen to the concerns. The concerns are quite real. If you remember your medical ethics and research ethics, you know that we have not been kind to minoritized groups when it comes to trials and really doing awful things. So that is part of the history. That is part of systemic oppression. And we need to realize that the concerns are very real. So deliver the message, share the stories. Stories are very powerful. Stories about, individuals that have gotten the vaccine and have done well, or else. And then earn trust and reach out to that community. So those are things that you can practice in order to advance the cultural humility model and advance those conversations for health equity. And I'll take the next slide, but I think I'm pretty close to the end here. Yes. Oh, Perfect. So I wanted to actually leave a few minutes to discuss anything that I may have presented, any reflections and comments from the audience. I am happy to answer those and offer my thoughts and also learn from you. As an educator, I love learning as well. Thank you very much for your time.
Thank you very much. I think there is one question in the chat, and is ideology part of cultural competency?
Yeah, that's actually a very interesting question. And when you are thinking about all the cultural competency elements, I believe that you may think about ideology as being one of those areas. Somebody has an ideology, and you need to understand what ideology is in order to engage in the conversation and engage in practices. So it can be thought of as, somebody that may actually know quite a bit about that particular ideology and may engage better in conversations. I personally think that cultural humility works with everything because it comes from the notion of, I don't know that particular ideology. Tell me a little bit more about it so I can learn. And then that will increase your competency in that particular area in the future. It's a good question.
It's hard for me to see any raised hands, but if there's anyone who wants to ask a question in the chat, I could read it. Here's another question. What do you recommend, having lived here, that we can do within our DEI mission to advance recruiting more physicians of color within our residency programs and within our individual practices?
Well, that is everybody's question. We all want to see the increase in physicians of color in all of our areas. In terms of the equity mission, I think that you need to remember that just a statement will not do. That especially this time, a lot of faculty of color and students of color and physicians of color are saying, that's it. The statement is not enough. I need to see actions. So it will be not necessarily just in your EDI mission, but in the things that you're doing to actually increase recruitment. Things like, I was surprised actually when I first arrived in the department and I asked, well, where are you recruiting? I found out that they hadn't even gone to SNMA, right, to the Student National Medical Association. There hadn't been a booth for Indiana University for years. So I recommend that you actually go to those conferences and sell Colorado, sell the programs because they're there. So the National Medical Association is predominantly for Black African-American medical students. A lot of residents and faculty have been part of that. The National Hispanic Medical Association, LMSA, also has those. So try to actually go out there and try to sell Colorado, and you will find definitely those. Colorado is a very attractive state, more so than Hoosier land here in Indiana. So if you could attract somebody from Puerto Rico to Colorado, you certainly can attract more residents of color.
Dr. Sotto, I have a quick question.
Yes.
Hi, Dr. Sotto, Leslie Brooks. Thank you so much for your talk. That was incredibly informative and thoughtful and inspiring. And thank you for joining us this evening. I have a question sort of along the same lines as recruiting residents. You talked a little bit about COVID vaccine and vaccine hesitancy and engaging with those communities. And the Medical Society has been part of conversations around how we increase equitable access, how we institute, not just increase, how we affect equitable access to the vaccine. And we've had some conversations with our major distributors of vaccine in our communities about how they do that. I wonder if you would talk just a little bit about what it takes to reach out to communities of color and what that looks like. I frequently feel like I hear messages like, well, we've made the vaccine available and they can come.
That's not enough.
But right, but if we're going to be good partners and good stewards and really focus on equitable access, how do we help guide them in terms of reaching out to communities of color and how to do that?
Yeah, that's a great question, Leslie. And I will say that this was the quickest cultural humility conversation I've ever provided. But here's a quick snippet. So I'm also part of the Indiana CTSI over here, and I know you have the CCTSI. I don't know, Suzanne Brandenburg, maybe I messed that up. But and as part of the CTSI, we actually have obviously the whole state impact through the CTSI, and a lot of our efforts have actually centered on community engagement. If you want to get anything done, find a good community engagement scholar or find really the community activists that will tell you how to do that. Some examples, and these are easy examples, right? Which churches are you visiting to actually sell the story that this vaccine will save lives? So there's the churches, there's the fairs that I know not many things are happening, but those organizations that actually put together those community fairs, like the Latino Institutes or for Black History Month, build those partnerships with those institutions. We're also trying from our end to do a web portal that provides education and engagement. So not only as a recruitment optimization site, but also as a way that individuals and communities can actually go and get the information that they need. So we're not just seen as the big bad institution going out there and saying, I'm recruiting, and not providing anything back to the community. So those are, just some quick examples, but there's so much more that we can do to actually reach those communities. But you have to mobilize people, and you can't do it just yourself.
Thank you.
Any other ones? Is there time for
anyone else? There is one comment, but if I just want to give the opportunity for any more questions.
This is Mark Wallace. I'm from the Weld County side of the Medical Society, and I'm curious if you have any knowledge of states or localities who are actually taking the equitable access to a level of very discrete distribution of vaccine. One of the things that's going on right now is there seems to be this scramble for vaccine. There's like a little bit going on at the federal level, maybe more under this administration. The states are getting vaccine. Governors are in charge of kind of deciding, when we move into different phases. And one of the things I've been surprised by, I've been on many calls recently with our Department of Healthcare Policy and Financing and the Department of Public Health, and nobody can point to a vaccine plan that says they have incorporated equity into the distribution model. They just say, oh, we want all of you to equitably, distribute it at the local level, but there's not an allocation that comes and says this can be used in this way. So I'm curious if you have any knowledge of, in your state or other states where people are being very, disciplined in their plan to say, if equity matters, we're going to not only distribute vaccine in a way in which it supports equity, but we're also going to measure our progress. And I know there's issues about creating barriers to people, identifying themselves in a certain racial or ethnic group. But I worry that if we don't measure it and report on it and distribute it in a way, we're all scrambling to kind of put the puzzle together in a very strange way.
Yeah, that's a great question, Mark. And I can't point to any model that I think is doing well, to be quite honest. I don't think we're doing well, and I haven't seen it out there. However, I do see little pieces of efforts that I think done in a way that it's actually actually planned, like even like implementation science. Like we need implementation science people. That if we actually do it in a way, it will advance equity. I have seen portions of, for example, we just received a transportation grant. Why would a med school need a transportation grant? Well, because we want to be able to pay for people that are in rural areas to actually go and get, the vaccine. So so little pockets of cool things that states are doing, counties are doing, but I don't think that there is a unified effort that, I can actually say, oh, that is working fantastic. So I didn't want to end the talk in the sad.
No, I appreciate it, because I mean, I think we're all we all recognize we're flying this airplane and building it while we're flying it, but
Yes,
I'm
yes.
just always open to, like, has anybody got a little bit of an edge on us to be certain that our distribution plan incorporates equity in a very tangible way?
Yeah, and I would offer this last piece that, before this year, and I saw it, right? As soon as I spoke about equity, diversity, and inclusion, there was a portion of people that would just roll their eyes. Well, this year, nobody can roll their eyes, right? This is the issue at hand. This is the task that we need to address in order to advance health equity. But we have had it all along if we talk about structural social determinants of health. And even if we don't want to think about equity as this big, concept too big to actually deal with, that if we break it down in terms of the structural social determinants of health, we may actually find out exactly what we need to do in all of those categories in order to advance health equity in relation to the vaccination. So I offer that. But
Thank you.
Any other questions?
This is Corey Carroll. I'm curious, in a bigger picture, I mean, the difficulty with people trusting in the healthcare system, which doesn't give them equitable care, is a really hard sell. Curious, has there been any studies in countries with universal healthcare systems if there's less problems and issues regarding the disparity and the trust of the system?
I am no expert on that, Dr. Carroll. I am sorry to say, but I do open the floor if anybody here has the answer to that question. I have not seen studies like that, but I can just tell you really quick. I think it was last year, MLK weekend. I was in the Netherlands as part of a global racial justice summit. It was fantastic. And one of the things that I actually learned is that they don't have the words for racism. They don't have the words for microaggressions. And when they're talking about these concepts, they talk about it in English because that's what happens in the US. So there are definitely some gaps there, and there might be some gaps in how the demographics of the population actually are tracked. And I only bring the Netherlands because I was there last year, and we saw the gap in actually collecting information and that kind of thing. But.
Okay, anyone else? There have been some comments in the chat box too. If people want to just take a read of those as well. There's been a bit of a conversation. So if there's no one else, I want to thank you, Dr. Sotto, for being here tonight and imparting your knowledge as we continue on our DEI journey.
Yes, thank you very much for having me. I put my email address there if you want to continue the conversation, or if there's anything else I can provide to you and your group and the community.
Thank you very much, Dr. Sotto.
Bye, everybody.
Thank you. Bye. So now I'm pleased to introduce Dr. Christine Reimer, the Assistant Dean of the Colorado University School of Medicine at the new Fort Collins branch.
Awesome. Thank you. I just first want to thank you all for choosing that topic, and thank Dr. Sotto for a great talk this evening. The pandemic certainly has amplified health inequities in our community and everywhere. It's certainly an appropriate and timely topic as we are rolling out vaccines and figuring out how to get that to populations in all demographics. So thank you. But I was given a few minutes to just talk about the new CU School of Medicine at CSU Fort Collins Branch campus and acknowledge the students who have been in this community over the past year during a difficult year also. Next slide, page. So just a moment to tell you what we're doing. So the School of Medicine is rolling out a new curriculum called the TREC curriculum next year. So next summer, this coming summer, in July, we will roll out this new TREC curriculum to our first class of 12 students who will spend all 4 years in the Northern Colorado medical community. On this campus, there'll be a One Health focus that overlies their clinical training. So One Health, for those of you who don't know, in collaboration with CSU, allows us to focus on this concept where health, human health, intersects with environmental health and animal health. And the experience for these students will start with just one foundational year, so different than what most of us did, where we had 2 years of basic sciences before we did our clinical training. One foundational year that's taught in systems. So for example, we're currently working on building the 3 weeks of GI. So within that GI system, they'll learn anatomy, pathology, pharmacology, histology, microbiology, pathology, all of the basic sciences within the unit, interspersed with even getting out to work in the clinical space a little bit during that first year, learning some clinical skills, and then also health and society content. And then they go into their second year. So their second year is what we used to do as our third year. It's their core clinical experience, and also different than what we did. In this longitudinal integrated clerkship, they learn surgery, internal medicine, family medicine, peds, OBGYN, psychiatry, and emergency medicine across the entire year. So they have a little bit of each of those every week, with some more immersive experiences in the hospital in surgery, medicine, and OB-GYN and peds. It allows them to establish relationships with patients over the course of the year and with their preceptors over the course of the year. And then their third year, they circle back around, do a little bit more advanced basic science training in cardiology, immunology, global health, and neurology, before by the end of their third year and into their fourth year, they are on their pathway to more individualized training, acting internships that we did as sub-Is, and then specific training to prepare them for residency. So this new 4-year curriculum will look a little bit different. Currently, we have third-year students from the Anschutz campus who've been in the community here since May of last year, doing that LIC, that longitudinal integrated clerkship, their core clinical years. Currently it's their third year, but that's the group that has been here before we start the 4-year campus. Go to the next slide. And so this is a group of people we are here to celebrate. So these are the group of students who chose to come here this past year in the middle of a pandemic to do their core clinical year. So I'm going to just introduce them from left to right. A couple of them are on this call tonight, which is pretty impressive because they had a shelf exam today. So you may all remember how stressful it was kind of building up to those shelf exams. They just had their peds shelf exam this afternoon. So from left to right is Madison Harrison, then Eli Feiner. I realize you can't see their faces behind the masks, but you can kind of get it. Next is Peter Boxley, Johnny Lane, and Emily Wolverton, who is on this call. Feel free to send her messages in the chat, or Emily, if you want to wave sometime, that would be great too. Chase Weaver, Frankie Jenny, and then in the middle of them happens to be one of our surgery liaisons, Caitlin Heisler with the black scrubs on there, Ben Massey, and Sophia Wolf, Nick Mason, and on the far right-hand side is John Michael Benson, who is also on this call tonight. So JM also. Feel free to send him some messages in the chat if you'd like. Thank you for joining to you. So we are celebrating this group tonight. We want to recognize the contribution they have given to this medical community. As you know, when we have learners here, it's a more vibrant space for all of us and improves care for patients. I think over the past year, this group of students has taught us certainly as much or probably more than we've taught them. We were so happy to have them join us and help teach us how to build a medical school campus in this community. And those 3 words on the bottom of the slide, flexible, tenacious, and kind, are words that class chose to describe themselves. And it was a good fit of words. So congratulations to this group who's almost finishing their 3rd year. I'll also acknowledge that Amelia Barber is on this call, and so she will be joining us for her LIC starting in May of this year. We're looking forward to having her participate, and she's waving. Next slide, Paige. This is the clinical leadership team who's been working on this project, and several of these folks are on the call also. If you want to send them messages and or please feel free to wave at the rest of the group. But Suzanne Brandenburg is the associate dean, so she is a general internal medicine physician who lives and works mostly on the Anschutz campus until she started this project. And actually, prior to the pandemic, she spent a fair amount of time up here. During the pandemic, we've had a lot of calls like this. I'm working as the assistant dean, so the on-the-ground sort of infrastructure organizer kind of person. Dr. Amy Ruppert, who's a trauma surgeon, is also on this call. She's the director of the LIC, which is the program that has gone live this year for the 3rd year students and has done a fantastic job, particularly during a pandemic. Dr. Una Giles is also on this call. So she's a pediatric hospitalist who has picked up the role of health and society content director, has really worked over the past year to get these students involved in the community with service learning projects and has done a fantastic job. Also on this call, Anisha, thanks for joining us. And then Karen Chaka, who's an internist also in Denver, has been working with us in the admissions committee as we try to find the right students to join us next year to matriculate into their 1st year. Next slide. So for each specialty in this core clinical year, we have one liaison who is helping make arrangements for these students and coordinating all of the work they do in the community and even the small group or didactic learning that they're doing on Wednesday afternoons. And you all will recognize a lot of these faces. They are your peers, and you will particularly recognize Dr. Birnbaum, who is on this call, who's at the bottom middle of this slide, and multiple preceptors when I look at the group of folks, the participants for this call. So thank you to all of you for everything that you have done to support the school and the students during this really difficult year. And I do want to specifically call out the family medicine residency in Fort Collins. I know Dr. Wozniak is on also. They have been an integral partner to the success so far of the medical school campus. Next slide. So while we have students in the clinical space, what we're building right now is the basic science infrastructure for that group that starts this summer. So Dr. Greg Amberg, who is a PhD PharmD, is the director of the basic science year. Also joining us on this call tonight in a leadership role is Dr. Mary Ann DeGroot, who is an infectious medicine physician, clinician, who also does some research and has been a fantastic leader and builder, liaison between the basic sciences and the clinical sciences and both campuses, the Anschutz campus and our campus. We're adding a couple more people to this group of faculty, but we're pretty close to putting everything together and being ready to start in July. Next slide. And so I just mentioned briefly that the students are in the community doing service learning projects, and that is something that's unique to this campus. And I just wanted to call out that these are the main projects that they're involved in right now, and we anticipate that these will continue across the 4-year curriculum. We have students working with the CSU vet students in a Street Dog Coalition project where our medical students are doing a needs assessment mostly now, but figuring out the needs of human owners who are experiencing homelessness, who are owners of pets that the CSU Vet Mobile Clinic has been taking care of. We have a pediatric respite care project, a neighbor to neighbor project for humans also experiencing homelessness and air quality program to align with that One Health concept. And then Harvest Farm, which most of you know is a rehab program for men. And we're building a migrant farm workers project in Greeley that will include more students, particularly over the course of the next year. And I'll go to the next slide. Yeah, so that's just kind of a brief overview of what's going on. I think that Dr. Norman's going to mention the students in particular later, but I did want to give them a round of applause and a big thank you for adding so much energy and excitement and medical knowledge to the community. And thank you for joining us tonight, where we, as I'm part of the Medical Society, are really happy to welcome you to Northern Colorado, and we hope to see you back here again someday. I'll turn it back over to you, Paige. Thanks for including us.
Thank you so much. Yes, and welcome. And if anyone has questions, you have her email there. And if anyone wants to get involved further. So, so now we'll move on to the business portion. And, you know, we've talked about in many other meetings, it's been quite a year for everyone, but I'm so proud of all that we've been able to accomplish this year. And I'm going to briefly go over the top highlights and then announce some exciting initiatives that we'll be launching. So earlier in the pandemic, we were able to provide PPE for no-code physicians in partnership with CMS. Now, NCMS is focusing on providing the best and most up-to-date vaccine information as we work on making sure our independent physicians have access to the vaccine and anticipated distribution, and that there is an equitable vaccine distribution that would be prioritized throughout all phases. We've launched other ways for members to get involved, including our Physicians Book Club and our podcast. And the last highlight I want to be sure to mention is that NCMS was the only component society to continue with a virtual legislative night this past fall. And during this event, we had a great conversation around the Colorado affordable healthcare option and maintaining Colorado's stable medical liability climate, continuing to give our members access to better relationships with our local representatives. As we move into 2021 and as my presidency comes to a close, I still look forward to what we have planned, including the continuation of our Physicians Book Club, our virtual education series beginning in March, and STEM initiatives with our local school districts in Northern Colorado. We are thrilled to be continuing our Physicians Book Club. You may have noticed that with your meal from the Rio, you had a book included. And this book was recommended by Dr. Sotto, and it's called What the Eyes Don't See by Mona Hanna-Attisha. And this will be our book for our next book club, which will take place on Monday, March 15th, and will be moderated by Dr. Leslie Brooks. Yay. And you'll see that we've also given you a bookmark to continue to use as you read the rest of the book club books this year. We're pleased to announce the launch of our 2021 virtual education series that will begin in March. Each month, we will have a virtual education event that will have CME credit available, even if you cannot attend live. So you'll be able to access that on our website and get the CME credit. Our topics are quite diverse, and they'll be kicked off with one by Dr. Doris Gunderson on the use of THC and vaping, and feature other topics throughout the year, such as how to best treat LGBTQ patients, physician burnout, nutrition, and more. Finally, our STEM initiatives include creating a pipeline of resources for Northern Colorado middle school and high school students. We'll be partnering with school districts across NoCo to bring physicians into the classrooms for panels and to grow programs that the district is already putting on. We can't wait to help provide resources to students in our area and to help build the healthcare workforce of tomorrow. Be on the lookout for how to sign up and participate in this through the emails that we send. So finally, before we move into our presentation for Physician of the Year, I want to be sure to recognize all of our members. Every member and physician in NoCo is a hero, especially this year, and I'm so very humbled to work alongside you. I do want to congratulate NCMS board member and candidate for President-elect Dr. Mark Wallace. The New York Times opinion staffers created the Fauci Awards to honor public health officials for the work they've done during COVID-19. Dr. Wallace, the former Weld County Department of Public Health and Environment Director, was one of 3 doctors featured. Dr. Wallace receives the Times recognition for his work to protect low-wage workers, namely the employees at JBS. So round of applause for Dr. Wallace. And now we'll go into the Physician of the Year and this year's Legacy Scholars. So we'll begin with our Physician of the Year. So Dr. Bernard Birnbaum of Fort Collins Family Medicine. Dr. Bernard, or Bernie Birnbaum, originally from Chapel Hill, North Carolina, graduated from George Washington University School of Medicine and has completed a family medicine residency at Thomas Jefferson University in Philadelphia. He then worked for 4 years in Arizona with the Indian Health Service. In addition to practicing full spectrum family medicine, he worked in a school-based adolescent health clinic and served as the chief of the Department of Family Medicine. His special interests include adolescent health and pregnancy, community medicine, public health and primary care integration, quality improvement processes, and the care of the underserved. He moved to Fort Collins in 2006 to join the Fort Collins Family Medicine Residency and has been the associate director since 2014. He was publicly elected to the board of the Health District of Northern Larimer County from 2008 to 2016, and he currently serves as the president of the Board of Health for the Health Department of Larimer County. Before I bring up Bernie on our virtual stage, we're excited to share this video to help honor him and welcome him as our 2020 Physician of the Year.
My name is Janelle Wozniak, and I am the program director at the Fort Collins Family Medicine Center and have the privilege of supervising Dr. Bernie Birnbaum.
I met Bernie as a resident, but I actually met him as an applicant.
I have worked with Bernie for the last 15 years now, and I can't even begin to tell you how much our teams enjoy working with him.
And when I went to med school, I didn't really find a lot of people that I looked up to. That I really thought that I wanted to be like. And then I had worked at some community agencies here in town and had a sense of wanting to be involved in the community when I came back here. And then I remember sitting in Bernie's office, and he had just like laid out the possibilities of community involvement here, all of which he had kind of established through his charisma and his connection and his willingness to get involved places. And I remember finally feeling when I was applying here and talking with him that this was somebody who I admired and somebody who I really, wanted to shape my life, kind of in the image of, to not make it too much of a charismatic leader comment there. But I really did look up to him in that moment, and he was a huge part of why this place seemed special to me.
He is an incredible advocate for our patients as well. We take care of primarily an underserved patient population, and Bernie finds a way to connect with every single patient that he sees, whether it's over food or fishing or something else. He always finds a way to connect with them and to make them feel heard and valued, and then finds ways to continue to advocate for whatever their needs are for their health. So
I had no idea. This is a weird year in particular to be nominated for this award, because I think the entire medical community, from the folks that clean the rooms in the hospital to the critical care docs, have been put in a position that we never really, I guess we theoretically imagined it, but never really imagined it. And I think that there's a lot of people working ridiculously hard who deserve honor, and I feel like I work hard, but I feel like there are people who work harder than me. So no, I didn't know that I was nominated and was very surprised.
Is that this year in particular, Bernie has played a really active role in working with the public health department and our community, and having his voice as a great source of information for the public and for these boards during this pandemic has been really invaluable.
I hope that they would say passionate.
I think that the one word I would use to describe Bernie is passionate.
Charismatic.
As far as teaching, Bernie's enthusiasm is, as I said, unparalleled. He is active in teaching in the inpatient setting, in the clinic, with procedures, doing deliveries, and always has something positive to say that inspires us all to want to learn more and do better.
I've always wanted to be a medical educator. That was an interest before I was a doctor, actually. I think my mentors when I was little were teachers, and I always wanted to be a teacher as much as I wanted to be a doctor, quite frankly. And so, in this context, I get to pollute young minds.
But at the end of the day, if things are difficult, why I feel proud to work here are things that he has envisioned or conceived of or established through working with people in the community. I mean, that's what Bernie does. He makes those connections and then builds that energy and brings people in to the work that he's envisioning, and it's wonderful.
And I think remembering the context of where people are and helping them find those ways to be healthy and well that are not necessarily medical is very powerful. And that's sort of why I wanted to focus on public health. I mean, that's why I wanted to get into public health work.
All right, Bernie, did you want to say a few words?
That was intense. I'm incredibly humbled and thankful to get to talk to you really briefly. This is an incredibly strange year to be nominated for an award like this. I look across this group of folk, and we have put out a workload within the past 12 months that none of us ever dreamed about. I look at some of the folks that aren't here, and I think of our critical care colleagues. I think of our ER colleagues. I think of the nurses that sit with patients and hold their hands. And I'm incredibly humbled because I think that they really deserve recognition this year. When I think about what makes me passionate is patients and loving patients. And I look at this group of people and I see a lot of people that share that passion. I'm thrilled that our keynote speaker tonight spoke about equity and spoke about how can we be humble in the work that we do. I would argue to you that we're all complicit in an evil healthcare system. We're all complicit in a way of caring for people that doesn't soothe our souls. We work to spend time talking about our wellness and our well-being, but in reality, the reason that we're not well is that we work in a system that doesn't work. And so my prayer for each of us as we go forward in time is we can think about how can we help our system work better? And how can we train folks and work with folks to work to make the system better? Anyway, that's what I would leave you with. I think we need to find our wellness in caring for the people that we care for and doing it in a way that is healthy and good for them and for us. So thank you guys very much.
Thank you. A well-deserved award with a very humble speech that I think everyone will think about. So thank you very much.
Thank you guys.
So now I'm pleased to introduce two physicians of the future. NCMS is pleased to award our Legacy Scholarship. As a reminder, our Legacy Scholarship benefits medical students in Larimer and Weld County and honors NCMS members who we have lost. So our first is Amelia Barber. She's a third-year medical student who hopes to practice community-based medicine as a generalist. She grew up in Estes Park and completed her undergraduate degree and EMT certificate in Fort Collins. She loves all things Northern Colorado and intends to practice here after her training. Alexis Girk was born and raised in Greeley and graduated from Northridge High School. After being awarded the Better Scholarship, she attended the University of Denver. She also performed research at Children's Hospital, where she studied orthopedic outcomes in children with neuromuscular disorders during the week, and then taught them how to snowboard on the weekends. Congratulations, Amelia and Alexis. All right. So NCMS is lucky to have such an amazing group of physicians that serves on its board of directors. And I'd like to take a brief moment to honor our outgoing members. Thank you, Dr. Kyle Hampton, Dr. Mohammed Latskani, and Dr. Curtis Markle for your service to NCMS. I also want to be sure to acknowledge one more outgoing board member who has truly gone above and beyond for 20 years with this organization. Dr. Jan Gillespie has been a board member for over a decade. Dr. Gillespie helped lead the transition of Larimer and Weld County Medical Society merger and continued to help train new staff to make NCMS strong over the years. She was the champion in our region on the legislative effort around advanced care directives and has continued to be a voice in advocating for independent and unaffiliated physicians. She has served as our treasurer for the past 5 years and has done an amazing job implementing a checks and balances system that has made daily operations in NCMS seamless. It is an understatement to say that her work and voice will be missed on this board, and the impact she has made is truly immeasurable. Let's thank and acknowledge this amazing work done by a virtual round of applause for Dr. Gillespie. And I will hand the floor to her for her last financial report. You're muted.
Thank you for those very nice comments, Claire. So I always think of finances as telling a story about your organization. And so they're not just boring numbers. So first I'll start with the income. And our income really comes from 3 sources. It's from our dues, our interest on our 2 CDs, and sponsorship. And so we thought that we would have maybe up to a 25% decrease in our income because we thought members would have financial issues because of COVID. And as you can see, that really didn't happen. Our dues took a little dip, but really pretty stable. Our interest income about the same. What did take a hit this year was our sponsorship. And if you think about it, people don't really want to pay for sponsorship for a virtual meeting, and everything pretty much went virtual this year. So we lost out on sponsorship money. So our total income dropped about $19,000 from last year. Then we'll go over expenses. Our expenses, to me, tell me what an organization is doing. Where you spend your money is usually where your heart is. And generally, we have that in 3 different types of categories. One is the meetings. Well, virtual meetings don't cost a lot of money. And so our meeting expense decreased. And this included things like our board meetings went virtual, executive committee meetings. We usually have like a meet and greet, a social. We didn't do that. Our legislative meeting, which generally cost us a fair amount of money, we did virtually. So there wasn't, the hotel cost, the conference room cost for that. The second is initiatives. And in the past, as you'll see, that $722 was actually tied to an initiative that was a 2019 initiative that expense came in this year. We did advanced care directives. We did a women's conference, an opioid conference. That's where our 2019 and 2018 money went to. This year, we did a book club that was virtual, and it really didn't cost a lot of money. The other big initiative that we did that wasn't public facing, and that's really what our initiatives are, they're our public facing initiatives. We did a reorganization of our society. We redid bylaws. We put a lot of policies in place. We did some diversity training for the board. We changed to a management agreement with Colorado Medical Society. All sort of internal things that really we wouldn't count as an initiative. Hopefully next year we'll see that initiative money go back up so that we can show work to the community. Our next expense was the directory, and we did publish the directory. However, we looked at it a little bit more closely this year, and we didn't print as many directories. And previous years, I hate to say, we probably threw away a couple of boxes of directories that after distribution, we just printed too many. So we're a little more careful with our costs on that. And then what's left on the budget is really kind of running the organization. and that includes the website. The website runs about $3,000 a year in costs. So I didn't do a line item for that. Our administrative costs has varied some, but not too much. This year, with the management agreement, it'll be interesting to look at. Next year, we pay just a little over $9,000 a month now to Colorado Medical Society. And that includes the executive director, and then office expense or some of our general liability. So this year, our total expenses went down $26,000. And then if we look at what is our profit and loss, it's on the next slide. Our profit amazingly stayed about like what it was in 2018. And if you look at that, that's because our income went down, but our expenses went down more. So we're doing well. And then we'll go to the balance sheet, which is the next slide. It appears that our assets have greatly increased by like $43,000, but this has to partly due to the fact that we changed accounting from one source to the CMS, and this has to do with prepaid dues. I don't think we really increased our assets $43,000 because our profits were only about $11,000 last year. So we'll just have to watch that next year. But if you still look at it, we have $400,000 in the bank right now. That includes 2 CDs. We're doing really well financially. And so I hope to see us increase our initiatives next year. Any questions about our finances? Okay, I'll turn it back over to you, Claire.
All right. Thank you, Dr. Gillespie, for all your hard work and your last treasurer's report. I'm sure you're celebrating as well. She's done so much work. So last, as we come to the conclusion of our business meeting, is now time to elect the next leaders of NCMS. We will now vote on our candidates for NCMS President-elect and NCMS Board of Directors. Their names are listed on the screen. Are there any nominations from the floor? Someone is super inspired and wants to join us now. We do have open board seats if you're particularly excited by the meeting tonight. So I'll give you a moment, but you can read there. Some of us are being reelected, and then we have some new names as well. So we're excited about that. All right, hearing none, may I have a motion to approve the slate of candidates?
This is Dr. Brooks, so moved.
Thank you. Do I have a second?
Corey Carroll, seconds.
Thank you for that. So if everyone could, this is kind of clunky and I apologize, but if people could try to turn their cameras on if possible, unless you're on the maybe treadmill or something along those lines, so we could see your hands raised when I call for the vote. So all in favor, raise your hands high. I'm sure Paige can see everybody. I cannot.
I can. Everyone's really positive, really positive.
So thank you for that. Put your hands down. Anyone opposed? Paige, you see any? And
we do not have any oppositions. Nope, no oppositions, Dr. Murphy.
Fabulous. So congratulations to our newly elected board members, Dr. Reimer, Dr. Breen, and I think we had one extra that Dr. Wozniak. So we are looking great. Oh yeah, Dr. Money. We didn't update my script on this, but I see we have a lot of fresh faces and it's going to be great. And I will turn it over to Dr. Norman, your new NCMS president. Cheers to the end of my presidency. Thank you.
Good evening, everyone. I'm Ted Norman. It's interesting to officially address you all in this virtual event as the NCMS incoming president. I don't think I would have expected to be banished to Zoom for my presidency, but I'm still honored. I'm excited with where NCMS is headed this year, and I look forward to joining our members for events that are really going to take our society to new heights. Before I talk about where we're headed, I want to take a moment and thank Dr. Murphy for the amazing work she's done as president. When we think about the card she was handed this year as she began to lead our society, it was one of the toughest hands we've been given in recent memory as an organization. Between several changes in staff personnel and supporting our physician members through COVID-19, this presidency was a job for 10 people. And Dr. Murphy was as good as 20 people, and in addition to keeping us afloat, she actually grew the society. She led 2 bylaws revisions, 2 strategic planning sessions, one specifically focusing on diversity, equity, and inclusion, and is responsible for leading the charge in growing our board of directors. And so I'd ask everyone to give a well-deserved round of applause for Dr. Murphy. Here's a round of applause. As our new board member, Dr. Reimer, mentioned, we're also very excited as a component society to be involved with the medical students, and we would like to recognize the current third years. It may have been a couple of years ago for me, but I did find one of the best things that got me through medical school and residency was coffee. So NCMS is proud to present these students with this coffee mug. See if you can make out the writing. And some local coffee from Bindle. Tasty little place to stop in Fort Collins down near Jessup Farms. And finally, as we close out this evening, we have 2 asks of you, and that is to get more involved at your own pace with 2 new initiatives that we're doing. First is champion groups, which is basically a fancy term for a committee, but the importance of this is we want to champion the best programs for our members, but we cannot do this without member input. These 2 groups, membership and education, allow you to get involved with the NCMS strategic plan at your level of comfort and availability. For instance, if you join the membership champion group, you actually have the opportunity to plan the next membership event that you want to attend. To learn more, you can visit our website or email me, which I'm putting in the chat box now, or you can find it on the website. And the website is NOCO, N-O-C-O, medsoc, medsoc.org. You can just Google Northern Colorado Medical Society and you can find it. Also, save the date for the education events we have planned, which are really inspiring, with topics including treating LGBTQ plus patients, physician burnout, and women in medicine. Our kickoff event of the series is going to take place on March 18th with Doris Gunderson, previously the CPHP medical director, addressing the use of THC and vaping. And finally, for those who picked up a meal, as Claire mentioned, you probably also got a book. This is going to be discussed at our next book club, and Paige can give you the information and the Zoom link on joining the discussion. You don't need to be a literature expert to participate, and it's in fact the first book club I've ever been involved with, and I'm enjoying it. So we want to thank you all for attending tonight's virtual show, and hopefully we can meet in person next time. Please also send any feedback on how we did tonight to my email or to Paige, our executive director, through the contact numbers on our website. Thanks and good night, and I hope the margaritas helped.